We will now move on to our next part of the evening, which is the clinico-social case discussion. The discussions on equity in health and addressing health disparities tend to be abstract. How do we bring equity into the discussion of the processes of history taking, physical diagnosis, clinical management, and prevention? In this session, we will be asking experienced physicians to discuss their approach to equitable healthcare in relation to concrete cases. The aims of this session are to highlight 1. The social and cultural understanding and patient perspectives of their illnesses; 2. The clinical approach to cost effective management, history, examination, diagnosis, lab tests, and choice of therapies; and 3. How to apply evidence at the bedside to ensure equitable care. With that being said, I would like to invite the moderators, Dr. Aquinas, Dr. Yogesh Jain, and Dr. Solomon Chelliah to moderate the session. I would like to request Dr. Krupa Merin Abraham, our presenter, to begin her presentation.
Good evening. I'll be presenting a clinico-social case discussion today. Presenting Miss M, a 21-year-old female who is unmarried and unemployed currently from Vellore. She presented to us in the month of June with the complaints of fever for 1 month, productive cough for 1 month, vomiting and loose stools for 1 month, loss of appetite and weight for 1 month. Coming to the history of presenting complaints, she complained of fever for the past 1 month with history of evening rise of temperature and night sweats. She also had other constitutional symptoms like loss of appetite and unquantifiable weight loss. She also complained of cough with whitish thin expectoration with no hemoptysis or diurnal variation for the last 1 month. She has also noticed vomiting, which was non-bilious, non-blood-stained, and was not associated with jaundice or any abdominal pain. She had multiple episodes of small volume semi-solid loose stools per day for the last 1 month with no blood or mucus in stools. 1 week prior to presentation, she had worsening fever with new onset chills and rigors for 1 week, and this was associated with breathlessness, which was initially MMRC grade 1 and progressed to 4 over a week. Coming to her social history, this is the family, this is her family household history. She is the third born to a non-consanguineously married parents. She has an elder brother and an elder sister. Her father had died in 2008 due to an probable acute coronary syndrome. She lives currently with her mother and her elder brother. Both her mother and elder brother lost their job while she was admitted in the hospital. She is unmarried. In 2008, her father, who had no comorbidities or no history of any addictions, had sudden onset chest pain and succumbed to the illness before he could be taken to the hospital. She has an elder sister who's married and settled in Chennai. Coming to the housing conditions, she lives in a house which is near to the railway track in Vellore town. They do not own the land where the house is situated. It is a Pakka house with 3 rooms. One was a kitchen, 1 bedroom, and a storage room. It has an asbestos roofing, and there was a bathroom and an Indian toilet present in the premises. There was an open drain which was noted in front of the house and an open canal behind her house. This is the open canal behind the house, and we can see that there is a lot of waste and contaminated land around her household. This is a little bit of open space behind her household, which is kept clean. This is the 3 rooms that they have in their. This is the 3 rooms that they have in their house. This is the bedroom where there is 1 cot, and both her brother, her mother, and herself sleeps in this room. This is the storage room, and this is their bathroom. This is the kitchen where they have a fridge and a gas stove. They wash the utensils in the open area which is present outside their home. This area is where they is the area that they use for washing the utensils outside. They have access to 2 water sources. One is from the government supply that comes once a week, which is very near to their house, around 100 feet. And this comes once a week and is not boiled, and they drink this water directly. They have another water source around 500 meters away, which is the water from this source is used for cleaning and bathroom purposes. The ventilation of these rooms, all of these rooms had only 1 door, and there was no window or any other ventilation outlets. The middle room, which was the bedroom, has a sliding metal door. However, the other 2 rooms have wooden doors, which were noticed to be damaged. They have electricity available in all the 3 rooms. Coming to the occupational history, she is currently unemployed. Her brother was working as a finance collection agent with a private company. When she was admitted to hospital with the above complaints, he had to take leave at sudden notice, and hence this led to his dismissal from the job. He is currently unemployed and searching for jobs. Her mother was working as a maid in 2 different households. However, she has also been unable to work since her daughter fell sick to take care of her. She has not gone for work since April 2023. Coming to the education, the patient studied only till 5th standard. This was when her father died, and she was studying in a private school, and her parents wanted her to continue in an English medium school. Hence, her mother refused to change her to a government school. Once the father died, mother was able to support only education for her sister and brother, who studied till 8th and 10th standard respectively. She tried to learn stitching from one of her neighbors. However, she has not yet become proficient in the same, and she's planning to continue her tailoring classes once she's physically well. She's also planning to write the 10th standard exam in the near future. Her mother is illiterate and her father is an 8th standard pass. Coming to the lifestyle factors, there is no history of any addictions or exposure to secondhand smoke. Diet, she eats 3 meals a day. Till the admission, she was a vegetarian and did not eat any non-veg items, including eggs. However, after the admission and discharge, she was advised to take 3 eggs a day, and hence has been taking the same currently. Coming to the social support, they live alone as a nuclear family. They are not in contact with her father's brothers or her mother's siblings. The neighbors are not in talking terms with the mother or the daughter since the death of her husband, and they are aware of the patient's current illness, and since then the contact has further reduced. Patient's sister's husband is working as a painting laborer in Chennai. They were able to extend minimal financial support during the hospitalization. However, they visit the family regularly. Coming to a cultural and religious factor, she is a Hindu and goes to a nearby temple every Saturday. There were no beliefs or practices that were identified which would hinder with or promote healthcare seeking behavior or affects the treatment plan. During the initial 1 month of fever, however, she was taking native treatment and home remedies for the fever and cough. Transportation facilities, her brother has a bike as well as a bicycle. Government and private buses are available from within 1 kilometer, and the access to the main road is within 1 kilometer. Coming to the economic challenges, as we mentioned, the patient, the mother and her brother are currently unemployed. Their current source of income is the 1,000 rupees, which is provided by the government to the mother. They also have access to ration to get the necessary food items. Social challenges wise, the family faces isolation from the rest of their relatives as well as the neighbors. Coming to health insurance, they do not have access to the Chief Minister's comprehensive health insurance scheme and or any other private health insurance. Safety at home wise, few factors that were noticed were the proximity of the living space to the railway track, uncontrolled vectors in the surrounding, and there was no regular fumigation which was happening in the area. There were locked of vector breeding sites that were identified, including the open canal at the back and the open drain in front of the house. And the land that they were living in was not their own. Coming to the access to healthcare, they had 3 options close by. One was the low-cost effective care unit, which is approximately 2 kilometers away from their home. After discharge, she was following up from the main hospital. She was following up regularly with LCCU for monitoring of bloods. Each visit to the LCCU costs around 20 rupees. They went via the brother's bike. Blood investigations were done for free, and however, LCCU was not able to give them the ATT. So she had to get a prescription from here and then come to CMC to collect the medications. CMC hospital was 1.5 kilometers from their home, and she's following up with our TB clinic here and is registered under Nikshay. The government Vellore Medical College is around 10 kilometers away from their home. Coming to the past history, there was no comorbidities, prior surgeries, or recurrent pneumonias in childhood, no exposure to TB positive persons. She is currently on tab isoniazid, 300 mg once daily, rifampicin 450 mg once daily, ethambutol 800 mg once daily, pyridoxine 10 mg once daily, and iron tablets. Coming to examination of the patient, her pulse rate was 90 beats per minute, blood pressure was 100 bar 60 millimeters of mercury, respiratory rate of 22 breaths per minute, and she was afebrile. Her weight currently is 41 kilos. There was pallor and leukonychia noticed, and she was also noted to have grade 2 clubbing. There was no peripheral signs of tuberculosis or malignancy that were noted. Our system examination revealed reduced chest movements on the left side with reduced resonance in the left inter and infrascapular areas, reduced breath sounds in the left infrascapular, interscapular, infraaxillary, and mammary areas, and scattered crepitations in the above mentioned lung fields. Coming to the investigations, her hemoglobin was noted to be 9 with an MCV of 63.5 and reticulocyte count of 2.87. She was noted to have low iron levels. Total count was 5,600 with 88% neutrophils, 6% lymphocytes, and 6% eosinophils. Platelet was 2.17 lakhs. Renal function was normal, and baseline LFT showed minimally elevated alkaline phosphatase levels. Microbiology investigations wise, her sputum expert was positive and it was rifampicin sensitive. Other blood culture and sputum cultures were negative. This is her chest X-ray, where we can see multiple miliary mottling in the chest fields. So coming to the summary, she presented with pyrexia of unknown origin, cough with expectoration for more than 2 weeks, and breathlessness for 1 week. On examination was noted to be thinly built, underweight, supraclavicular hollowing was there. Pallor leukonychia was noted with no peripheral markers of TB or malignancy, and reduced air entry with scattered crepitations in the left infrascapular, interscapular, mammary, and infraaxillary areas. So the clinical diagnosis was a parenchymal pulmonary disease with fever and constitutional symptoms. Probable infectious etiology and probable pulmonary tuberculosis was considered. So medical diagnosis was miliary tuberculosis, iron deficiency anemia, and rifampicin-induced liver injury, which happened later in the course of her illness. Coming to the social and contextual diagnosis, education access and quality wise, we have noted that the patient as well as parents were poorly educated. The mother was illiterate and the patient herself was educated only till 5th standard. Coming to healthcare and quality access, quality wise, she had accessible, good quality and affordable healthcare options for her. Nutrition was noted to be poor prior to the illness. Coming to neighborhood and built environment, we saw that she lives in a semi-urban area with poor vector control, poor ventilation, and overcrowding was noted. Social and community context-wise, the family was facing social isolation and lack of social support. There was a stigma which was evident with the interaction of the neighbors, and they faced unemployment. Economic stability-wise, they had poor economic stability. They had loans and medical expenses and lack of a stable income. Coming to the treatment details, she initially presented to our low-cost effective care unit when she had the worsening breathlessness and fever. She was admitted from the casualty in LCCU in view of hypoxia and breathlessness. Sputum test sent from LCCU came back positive and she was started on fixed dose ATT. On the second day of admission to LCCU, however, she had worsening of breathlessness and she was shifted to main campus in CMC as she had increasing oxygen requirement. She was admitted in the ward initially, however, noted to have worsening tachycardia and tachypnea, and her oxygen requirement further went up. Hence, she was shifted to ICU and required NIV. She was gradually tapered from the non-invasive ventilation to oxygen and then room air. In the main campus, she was registered under the NTEP program, and this is her NICSHE number. Day 10 of admission to the hospital, we noted that she had elevated total bilirubin, direct bilirubin, and alkaline phosphatase levels with mild elevation of liver enzymes. Probable rifampicin-induced liver injury was considered. Hence, isoniazid rifampicin pyrazinamide ethambutol regimen was changed to amikacin, levoflox, and ethambutol regimen. The first-line ATT rechallenge was initiated once the liver enzymes normalized. Coming to the total expenses of treatment, the hospital bill was 2,19,978 and 100% concession was given for this direct expense. The indirect expenses wise, there was a loss of income to the brother who earned around 10,000 rupees per month prior to the hospitalization. Transportation and considering the transportation and food for the bystander for almost 1 month of her hospitalization comes to around 3,600 rupees. Their house required some renovation by the time she was discharged from here so that she could go to a safer place. So they had renovated the bedroom and they had to refix the roofing as well as the doors of the bedroom, and this costed them around 1.5 lakhs. Coming to follow-up and monitoring, after discharge from the main campus, once she was hemodynamically stable, we had discharged her. She was admitted back to LCCU to continue the ATT rechallenge. She was admitted for 17 days in LCCU and ATT was gradually rechallenged. She did not have any further evidence of hepatotoxicity. Once all the first-line ATT drugs were restarted at maximum dose, she was discharged from LCCU. She was asked to follow up weekly for checkups. Currently, she is following up monthly since the last month, and monthly medicines cost her around rupees 1,100, and she is given 75% concession for this medication and has to pay around rupees 300 for her ATT each month. Investigations, mainly the liver function test, was done for free for her at the LCCU also. Coming to multidisciplinary collaboration in the main campus hospital, when she had features of rifampicin-induced liver injury and evidence of severe sepsis with negative blood cultures, an ID consult was sought, and they had advised to continue the current line of management and also advised to re-challenge her with first-line ATT. Once she was discharged from here, we were able to collaborate with our low-cost effective care unit so that they could manage her for another 17 days when the ATT was re-challenged. We also have a social worker who regularly visits the family, and they have been given contacts for ease of access to healthcare. Coming to patient's idea, concerns, and expectations of the illness, she understands that she has a lung infection which could spread to others via close contact. She understands that cure is possible with treatment and is compliant with her medications. She is concerned about spreading the infection to her mother and brother and about the financial burden that the illness has caused. She also expects to be fully cured by December by the time she finishes her ATT and expects to go back to learning tailoring and wishes to support her family financially. Thank you.
Thank you, Krupa, for the very detailed presentation. Just wanted to ask you a few more points. One is, she's a 21-year-old girl diagnosed as a miliary TB, but I did not hear from you anything about her menstrual history. Because being a miliary TB, she must have had a hematogenous spread. So genitourinary TB, whether you ruled out that possibility, because I didn't hear you speaking that.
She had regular menstrual cycles, ma'am. I'm sorry, I forgot to mention that.
Another thing, I did not hear you said the body weight. What was her BMI? Very important in a TB patient to see the BMI and whether she belongs to low BMI, even if it's a low BMI, very low BMI, or what it is. That was also not pointed out. Then the investigation cost is it's unbelievably high. I mean, if she was in a primary care setting, it would come to, of course, we do the PCR test. It comes to 700, but it's all free of cost. Within 1,000 rupees, everything, and it's completely free for the patient. But of course, in a tertiary care setting, I understand it is, 2 lakhs. It is way high. 2 lakhs, it's a way high.
Sir, ma'am, that was the direct expenses, including her hospital stay, ICU stay, for 1 month, ma'am.
I think this would. I'm actually. I'm amazed. How does CMC even think about a patient with tuberculosis for about 17 days of hospitalization having to pay 217,000 rupees billing? I'm not saying that they paid it, but there is something. There's something really wrong, if I may say, about the billing that is happening here. It's not who's paying, but yeah, but let's give this fact that this patient, this young woman had an illness which was what would be now called as severe tuberculosis, and that is 30% of people that have been found by this Tamil Nadu study. But Yeah, you carry on, but we'll talk about some of those things.
Yeah. Yeah, then also I was surprised. You said the patient was asked to take 3 eggs per day. You know what is the cost of 1 egg? Whether in such a poor woman, how can she even, I don't think 1 egg per day, she may not be able to take at home. I mean, we doctors, we advise 3 eggs per day, 2 eggs per day, but whether she, I don't think she can afford to buy because 1 egg costs so much. And for the TB patient, nutrition is now accepted beyond doubt as a therapy, as part of the therapy. So in addition to the ATT, good nutrition support, we need to, I don't know whether Tamil Nadu government gives some money, but if it doesn't, such a young patient, we probably will have to find ways and means to support her nutrition.
It's one more way, like if you get some sponsors for the treatment. There are one more, I think you told she's got a loan, the family. So they must be paying a lot of interest for that, which I have seen. So some local, like we are in a small place, so it is okay. All I'll do is just write a letter to the Marwaris. They will come and help. So let that CMC maybe having some contacts, to give some, at least if a loan is taken care of, then that will help the family to come up.
If I may, can you go back to your slide? Show me that X-ray chest, if you can. Can you run these slides? Yeah. Krupa, what do you think is the diagnosis on the X-ray? Can you say it again if you wish to?
So, miliary TB, sir.
Okay, that's your diagnosis. Anyone else in the audience who wants to say what is the diagnosis on the X-ray? What else? So there are nodular, whatever the micronodules and whatever. Anyone else who wants to take a stab at it? What is the diagnosis on the X-ray? Anything else? Anyone wants to say? Huh? Anyone else? Any other possibility that you see on the X-ray? In a 21-year-old girl whose weighs 41 kilos, can you not see poverty in this, or deprivation? Forget about the biology, This is an X-ray of an extremely deprived person, and of a person who's, who's embodying, this finding, but this is not the diagnosis. This is if we are only talking about the so-called biological manifestation of her diagnosis is that she's paying for social shit, of being deprived, coming from and deprived at multiple levels. No, it's not the fact that she got some bacteria from somewhere which has got progressive disease, resulting in a bacteremic seeding of her interstices of the lung. It's not that, and that would be very, very biological way of looking at it. No? But I think the diagnosis, I would have loved. Can you go to your diagnosis slide? Yeah. So yeah. So is this your diagnosis? I have a problem with the biomedical bit of it also. This is miliary tuberculosis, certainly. iron deficiency anemia because you did an iron study. This is not available for most of us, wherever we practice, because this is a CMC, in the tertiary, in the referred center, that you could even get an iron this thing. I would have just left it at anemia, because we don't know whether the anemia of chronic inflammation would be also contributing to this. But I don't think you can make this diagnosis of rifampicin-induced liver injury on this. Rifampicin is one of the least hepatotoxic first line ATT. It is pyrazinamide followed by INH, it's followed by the others. But and to be able to sort of say that this is rifampicin causing it because there is an ALT, there is an alkaline phosphatase which is higher up. Cholestasis is more common, but I think it's difficult to say for that. But my thing is, go to the diagnosis. Yeah, I don't see undernutrition being mentioned as a part of the biological diagnosis also. Forget about the social diagnosis that you might want to make it. So pardon me my saying, someone with this 41 kilos, if it has become so normalized in our eyes that a patient with tuberculosis is supposed to have a BMI or a weight of 41 kilos, and someone can do a quick calculation. If suppose her height is even a modest 152 centimeters, what would be the BMI? Can you do this quickly? I mean, 152 centimeters would be a very modest height in a community. 17 point. Okay, she's undernourished by that thing. Suppose her height is anything more than 152 centimeters, it might get into a BMI of less than 16, which is called as, and we know that and she's at high risk of not only having complications that she has had, but also her outcomes. Do you think she's likely to become with her lungs becoming well, which would be a concern that you would have when you start treating, and how would she emerge out in future, which would be something that I would be concerned. I would really now think, if you it's possible to mention all the next slide. The next slide mentions all the possible factors that contributed. But would you like to give us, in a phrase or in a sentence, why do you think she got such a bad tuberculosis? This is not an ordinary tuberculosis. No, this is a 21-year-old. I thought miliary tuberculosis was the domain of the kid doctors like I have been in the past. But we do obviously see miliary tuberculosis. But in if I may ask, the pundits in the room, MD medicines like all of you, some of you, what proportion of adult tuberculosis is miliary tuberculosis? It's not. I wouldn't say if you do a BMI stratified differentiation, I think miliary would be still common among would be still seen among many people who are undernourished, severely undernourished. But among people who have a BMI of 20 plus, I think it would be distinctly uncommon, isn't it? So I would really want you to say, as a star, resident that you are. Sorry, you're a resident or you're?
Yes, sir.
Sorry. Why do you think she got? What does it come to your mind? Why does she get such a bad tuberculosis at an age of 21? I know tuberculosis is common among adolescents and among the young adults. It's a disease of the young adults and the adolescents now. Though we do get to see a lot of elderly tuberculosis now. So, yeah, I would want you to think, this why question. Why did she get such a, what would you attribute it to in the pecking order of importance? Why did she get such a bad tuberculosis? Because it's going to color her future journey. Not to put in your spot, but still, we want to take first stab at it. Why do you think she got this bad tuberculosis? I mean, this question must be in your mind, no? You don't see a miliary tuberculosis who's sputum positive. Miliary tuberculosis are usually not sputum positive. Obviously, she must be having an alveolar disease also along with the interstices that miliary tuberculosis is. It's a and she was positive on the spot sample, correct?
Yes.
So which is like her bacillemic load, bacterium, the bacterial load in the sputum must be maybe 10 to the power 12, or maybe more. So why do you think she got such a bad tuberculosis? Would you like to hazard a guess?
The poverty that has led to malnutrition and overcrowding mainly as her main risk factor. Lack of access to.
Can someone inform me? Maybe you can also. The international classification of the ICD-9 includes extreme poverty as a diagnosis. I think it does probably, but just forget that. Why do you think she got such a bad malaria?
Malnutrition is one factor, sir.
Why was she undernourished? I mean, you answer that the causes, as Harsh was saying about causes of causes of causes. Why was she undernourished?
Lack of education regarding good balanced diet, lack of access.
I don't think anyone in this country significantly becomes undernourished because of lack of education. Because what you first want the food, and maybe you can become obese because of lack of education. Acha. Sorry, I think, should we have an open house, or should you only want to start first? Or why was she undernourished? Why was she lack of? Come on, don't tell me. Why? In her case, she lost her father when she was 8 years old, wasn't she? Something to that effect.
2008. Sir.
She was, maybe she was 7 or 6 years old or something, no? So a broken, when you lose one of the parents, and particularly the more earning person, maybe the mother was also earning, but the more, income was coming through from her father. This is such a destructive thing for the entire, the entire economy of the family. And since most people in this country still are buyers of food, so food will suffer. I don't know whether if I were you, I would have also looked at the nutrition of the brother and the mother also. Did we do the weights? They would also tell you about the food situation at home. Since she's still an unmarried girl and without kids, but it would be also telling you whether the mother is able to, what was her BMI? Forget about her BMI. I would be also interested in knowing. And this is obviously there is the PDS that is available in urban Vellore also, isn't it?
Yes,
30 kilos of rice, which they must be in, and 30 kilos of rice is not enough for someone who's consuming 80 to 90% of calories from rice and carbs in a family of even 3. So do you have a guess how much carbs that we eat every day? How many cereals we require every day? If you're even eating the Indian data of 80 to 90% calories coming from cereals? Usually, I mean, sorry, not to start a class on how much food we require, but 450 to 600 grams is the NIN's suggestion about cereals that we need to consume a day. If provided in this, mention that as when you are eating, a sort of a balanced diet. But so 600 grams per day for a family of 3. What adults? How much of cereal would you require? 1.8 kilos in a day, and therefore, something like 48 kilos in a month for the family of 3, which is not the thing that she. And with the rice being at about 60 rupees a kilo now, or 50 in urban Vellore. Anyone who's buying rice here in your own in Vellore, how much do you buy rice for? If you So do all residents in medicine know the prices of all the foods, if I may? Frankly, when you buy, if you don't know it, then you wouldn't be, Emmanuel mentioned about lived experience, living like even a consumer of food. I think it's one needs to know when one is dealing with people who are coming to you from the city. What are the prices of food? You certainly mentioned about the money that was spent on the fuel. No, you mentioned 20 rupees. I would have loved to say how much are they spending on food if they are, and how much of, if not money, how much money money they've been spending on food, buying food also. Why? And and the choice that you said that they were vegetarians. I did not see you talk about the social group this person belonged to. You didn't mention the caste. I would have wished, in a heterogeneous community that Tamil Nadu, that Vellore is, that you would have mentioned the social class that the social caste group that this person belonged to. Was this person, and you mentioned about some discrimination from the neighborhood, whether the person was a Dalit who was staying next to someone. Those things are important. And tuberculosis itself is stigmatizing, but our caste group that we come from is far more a reason for discrimination in this country. And someone also say a Dalit or a tribal with tuberculosis is even a larger reason for discrimination. And I think that would be my diagnosis. I would say this person is vulnerable to, I would even add in my diagnosis that this person is vulnerable to have a life of, that might translate into maybe inadequate cure. I would say the risk of, not completing treatment, maybe not surviving. There is data to show that every BMI point lower than normal, your risk of death on treatment also keeps on going up with every point BMI that there is. And certainly if you have a BMI lower than 16, then your risk is 5 times higher than if your BMI is over 18.5. So those would be important to know when you want to prognosticate even at a teaching level, where you're going to go. So, she required oxygen, she was so bad, tuberculosis may on, at admission, I think you picked up, this must be one of the most severe manifestations of poverty, if I may say, of deprivation, maybe, and and it's likely that if you look at those things, this father of this woman, this young woman, must have died at an age of 40 odd, because she was only 7-8 years old, or 45, and am I dying at that is also a reason for me. I will be looking at what all was happening, but whether he was a smoker and all, you probably didn't mention.
He's not.
He was not a smoker, but so if he was a non-smoker, dying of an MI at this thing, I think this is there are multiple things that are happening in this family, as of which tuberculosis is only one biological embodiment. I'm not able to restrict my diagnosis of this. You rightly mentioned medical diagnosis, but I would say if you want to take a social diagnosis and a complete family diagnosis, there are many things that are going beyond this, and so you didn't mention about INH resistance. You don't do this in your at CMC. You don't check for INH resistance if rifampicin is sensitive.
So if we have a culture positivity, if the MZ turns out to be positive, we'll go ahead with the MZ is awaited.
We are waiting for the
MZ for the culture growth.
How many days has it happened?
2.5 to 3 months.
2.5, 3 months.
Yes.
MGIT comes in 9 days or even 48 hours of incubation, and then 9 days the report should be there. I mean, I think you should check it out. Yeah.
Okay, Krupa, now when you follow up this patient, what all you will look into?
Ma'am, compliance to medications,
Okay.
improvement in nutrition, and
How
weight
will you
gain,
assess the nutrition?
diet history to see how much she's able to take calories and proteins.
So Tamil Nadu doesn't give any food for TB patients. We don't have a tuberculosis food rations program. Huh? No, that's not rations. It's cash enough for one meal in a CMC bill or a restaurant. For one.
Okay, nutrition and then
Weight gain and
see this patient is gone deep into debt post TB. Not only she, her family too. Now you will have to follow up her family members. They also will be developing TB sooner or later. So you have to
screen them.
keep a watch over them. And probably the medical social worker has to visit the family and see what is a nutrition intake like. Because it's we did a clinical diagnosis, we treated, but the after effect is the entire family is deep into debt. So this has got its own effects on the health of the entire family. So we need to be aware of that, because as doctors, we think by prescribing the medicines, it's over. Our work is over. Our work is not over. It begins probably that time. And if there is any young children in her neighborhood, we need to call them also and examine them.
Any other questions from the audience? Thank you, Krupa. I was also very happy that you have, in medicine, we did not have, when I was there, medical, this thing, social workers going, thought was only in the community health, but that's a very good thing. I met the social worker, he's going to, he's very sincere, and I'm sure you'll do a good job. You've done a good job. Congratulations, and thank you.